Good evening, everyone, and welcome to the second episode of the VRchannel by the Vitrio Retina Society of the Philippines. My name is Jeff Lim, and I will be one of the moderators this evening. The VRchannel is a platform we created to allow us to communicate and convey knowledge and expertise online in the field of vitreal retina. We try to feature both local and international experts, and we've opened our platform to retina specialists and our fellow PAO members. With me to moderate this evening is the president of the VRSP, Dr. Joanne Loy. Hi, Joanne.
Hi, evening, Dr. Jeff. Good evening, everyone. Hope all of you have remained safe throughout the pandemic. While physical face-to-face meetings have stopped, our out your smartphones to Sorry, I think I had a technical issue. Dr. Jeff, can you hear me?
Yes.
Okay. So at a certain point in tonight's session, we will ask you to bring out your smartphones to scan a QR code flashed on the screen. And through this, we can make the session a bit more interactive as you can participate in the polls during the session.
That's right, Joanne. The audience can also post questions and comments in the Zoom or YouTube chat box, and we will try to address these questions in the question and answer portion of the session. At this point, we would like to ask you to bring out your phones to scan the QR code on the screen or click on the link posted in the chat box so you can participate in this poll. The poll question is, how would you manage a phobia involving juvenile retinoschisis?
Okay. Okay, so just keep on answering the poll because we will show the results later in the program. So before we proceed to the program proper, allow me to thank our sponsor for this evening, one of our consistent and reliable partners, Alcon Philippines. Let me acknowledge the presence of Mr. Jatin Mital, the Commercial Manager of the Surgical Division of Alcon Philippines. Hi, Jatin.
Hi, Doctor. Good evening.
Good evening. So can we have a few words from Jatin, please?
Yep, sure. Thank you very much, Doctor, for a warm welcome. As you rightly mentioned, I'm Commercial Manager for Alcon Surgical Philippines Business. It's my great honor to join you all today and welcome all the participants joining this episode of VRchannel. On behalf of Alcon, would like to congratulate and appreciate efforts of VRSP organizing committee and current president Dr. John Loy for working so passionately for continuous medical education. A special welcome to our guest speaker, Professor Lam. I'm sure there is a lot to learn from his expertise in the field of vitreoretina. Alcon continuously strives to bring innovation and new technology for our dear VR surgeons. In line to this, we are transitioning all our Alcon Constellation users to advanced ultraviolet cutter with 10,000 cut per minute. I am very thankful to Professor Lam as he agreed to share his knowledge and experience with ultraviolet cutter from Alcon later today. To all the ophthalmologists watching this episode, rest assured that Alcon will continue to support Adopting to this new normal will bring more and more educational events and webinars to keep you updated with the advance in technology. For more educational tools, you can also visit our website, alconexperienceacademy.com, which is absolutely free for all the ophthalmologists and their support staff. Again, please reach out to any of our Alcon associates if you have any query or concern for any of our products. And our team will be happy to assist you either remotely or through a face-to-face visit. Rest assured, our team is very committed to support you even during this tough time. Once again, thank you very much, VRSP, for having us as one of your partners. Good evening to you all.
Thank you so much, Jetien. Thank you, Alcon, for always supporting the activities of the RSP. Dr.
Thank you,
Jeff?
Jatin. Thank you, Jatin.
Thank you.
We asked a questions to the attendees a few minutes ago. How would you manage a phobia involving retinoschisis? And the results show 44% would prescribe topical dorzolamide, 44% would do surgery PPV with island peeling, 6% will observe, and 6% will refer to your friendly neighborhood VR colleague. Thank you.
Okay, so Dr. Jeff, for tonight's topic, we were actually asked to choose between a lecture on diabetic retinopathy or juvenile retinoschisis. So eventually, we decided on a discussion on retinoschisis because we feel it's a topic we don't really get to hear much of.
And for tonight, we are very fortunate to have one of my esteemed mentors, Professor Ching Lam. Professor Lam completed his ophthalmology residency in McGill University in Montreal, Quebec, Canada, and obtained his vitreoretinal clinical fellowship in the same institution. He was with the University of Toronto from 1992 to 2016, achieving numerous teaching awards from both the Faculty of Medicine and the Department of Ophthalmology in the University of Toronto during his tenure. He is a vitreoretinal surgeon with clinical interest in adult and pediatric retinal diseases. He has published more than 80 peer-reviewed articles in various publications and has authored 7 book chapters. He has also received several awards of distinction from various organizations like the American Academy of Ophthalmology, Asia Pacific Academy of Ophthalmology, and the American Society of Retina Specialists. Currently, he is a clinical professor of the Department of Ophthalmology at the University of Hong Kong. It is my honor to present Professor Ching Lam.
Thank you very much, Jeff, for the kind introductions. It's always a pleasure to be part of the Filipino community for the presentations. I also want to thank Sherman for offering the invitation to participate. Particularly also for your president, Dr. Joanne Loy, for being so kind and offered the invitation to take part in the Zoom meeting. Although I like the Zoom meeting, I've been doing that for the last, I think, 3-4 months already. I still miss coming to Philippines. So at any time, if I have to trade off a meeting, Zoom versus a face-to-face meeting, I will jump on the plane to come to Manila without hesitation. And then spend the extra time in Cebu and relaxing after the conference. But in any case, we are stuck in the current situations, and I am glad that I have this opportunity to take part with the rest of your group. So I'm going to start sharing this screen to go on to my presentations. And can you see the PowerPoint presentation?
Yes.
Okay, good. So I'm going to fill the screen. That was actually very useful to have that poll questions. Looks like there's actually a fair bit of information that people already know about the juvenile retinoschisis and the management of it. So I'm just going to highlight some of the discussions. Hopefully, we can all kind of get a chance to discuss this. I'll start off with a case history. It's a 9-year-old boy who was diagnosed with bovine retinoschisis. In fact, he has confirmed with the genetic testing that was done back in December, and he was referred for further management. And let's see, let me advance this. And oh, sorry, so that's the slide. So here is the vision in the right eye is count finger, left eye is 20/70, and the anterior segment essentially is normal in both eyes. So here's the wide field photograph of the right eye. You can see there is a inferior elevations of the retina, was thought to be a retinal detachment. In addition, the left eye, there's looks like also infratemporal elevations of the retina, and which turns out to be a schisis. And the confirmations of the clinical finding can now easily be done with the spectral domain OCT. Although this is not the best, but you can certainly see a retinal detachment as it scans vertically through the right fundus, and horizontally you can see part of the retina there. In the left eye, you can see the schisic changes in the fovea in both the vertical and horizontal scan. And then in the inferior elevations, you can see a very typical inner retinoschisis and very thin inner retinal layer, and the retina is not detached. And there's also other cystic changes along the horizontal cut of that OCT scan. So basically, you have in the right eye a macular involved retinal detachment, and the left eye you have a inferior retinoschisis. So what's the management? So as we are quite aware that the X-linked retinoschisis involved a young boy, because the X-linked relationships of this genetic pattern, and they often present with bilateral reductions of visual acuity. It can range from very mild to quite severe, and the average visual acuity is about 2100. And they typically present with full field schisis, and on clinical examination, it looks like a spoke wheel pattern on the macula. It accounts for about 90 to 98% of the time. And you can also see peripheral schisis in terms of a splitting of the retinal layer. The retina looks particularly very thin, and often you see it in both eyes, and it involves in the temporal area mostly, and you can find in about less than 50% of patients present with X-linked retinoschisis. What I find interesting is that different from other retinal disease in children, this particular group of the patient has hyperopia instead of myopia when you see retinal detachment. So that could be a clue to help you to identify patient belong to this group. And we all know the genetic defect is there's a mutation in the RS1 gene on the X chromosome. And up to now, there's actually 191 different mutations being reported. And the main defect is this protein called retinoschisin. Essentially, it's the tissue glue, you can think of it that way, that holds the retina together. And with effective retinoschisin, then you get the splitting of the retinal layer. And before, people thought it was the Mueller cell layer that was being damaged because of the ERG changes that you see. But as it turns out, it actually is the connection between the photoreceptor and the bipolar cells. And typically, you have these negative forms of ERG, where the B/A wave ratio is less than 10. So you can see on the diagram here where the normal ERG is, where the X-linked retinoschisis ERG looks like in the dark adapted flashes and the dark adapted bright flashes. That used to be the way to confirm it, but nowadays, SDOCT probably is the better way to confirm it, and that is quite useful in terms of identifying the pathology and confirming the treatment. And here is a typical OCT appearances of the fovea, and this is in the peripheral schisis when you're not sure whether it is a retinal detachment versus schisis. The OCT can make the distinction very easily. The cause of decreased visions, besides the foveal schisis we just saw in the last slide, are the causes. Sometimes the macula actually obscured by the schisis cavity. Here's an example of a case where you have retinal detachment involving the macula with a very significant size outer retinal hole. As you know that you need the inner retinal hole and outer retinal hole simultaneously to have a retinal detachment. Otherwise, if you only have a inner hole without the outer hole, you only have the schisis without the detachment. Here is a case, you can see the very bolus retinal schisis and obscuring the fovea. Here's another case, you can see the very thin, very atrophic looking retina, but the retinal vessels are easily seen. This often can be confused with retinal detachment. The surgical options are either screw buckle or vitrectomy. And screw buckle can be done if you can identify and particularly the outer retinal hole, and the buckle can be placed in the location of the retinal hole to support them. They are particularly useful if there are multiple peripheral breaks. And vitrectomy are ideal for the case where you have vitreous hemorrhage or when you have a significant retinal schisis that you might have to do an inner schisic wall retinectomy or retinotomy. So the situation when you have to excise the inner layer of the schisis is when there is a kind of multiple layers of the inner wall. Sometimes they are in a very attenuated thin area. The blood vessels are kind of hanging, overlying it. And that's probably the reason why you need to do the surgery to diagnose or treat those vessels, because those vessels are pulling and can break very easily and cause vitreous hemorrhage. And what's interesting is that if you look at the inner schitic wall, the posterior edges of the schitic wall are often taut and under tensions, and that's probably where some of the pathology occur. We can cause progressive elevation of the retina, and that may be the location for the tractional retinal detachment. And some of the surgical management in those is to pay attention not to too aggressive to trim the posterior edges, because in doing so you could easily convert a tractional detachment to retinoschisis detachment if you inadvertently enter the retina or create a retinal break in that locations. Other reason to remove the inner retina is to allow better visualizations of the retinal breaks, and they are usually located in the posterior limit of the schisis. In most of the cases, silicone oil are needed, especially the cases involve children, where otherwise the positioning will be difficult with gas alone. Here is the case that we just talked about, and I'll show you the surgical video of this. You can see there are already subretinal fibrosis from the PL, and there are large outer retinal hole. So like most cases, first thing to do is to manage the posterior hyaloid. And so triamcinolone was injected to help to identify the hyaloid. The cortical vitreous detachments was created. And in a setting where there is already a retinal detachment, it's sometimes hard to continue the PVD to the periphery. So in this case, heavy fluid was used to help to tamponade and to support to make sure that the retina are stable before you can progress to do more of the posterior detachment to the equator and to the periphery. And once the peripheral vitreous was able to elevate it, then you can do the scoring then to remove all of the peripheral features. And using the brick as an access to the subretinal space, the subretinal band was removed. Then additional peripheral carbon fluid was added to allow drainage of more of the subretinal fluid. Then endolaser is then to apply to both the inner and the outer retinal hole. And gas fluid exchange was done, and then you drain further of those subretinal fluid through the pre-existing retinal brick or the retinotomy that you make during the procedure. And then more laser is applied to any of the untreated area. The silicone oil is placed into the eye. Here's another case. This is actually an interesting case. I don't know if you can see it on the pictures here. You can see there's actually a dense vitreous hemorrhage, which is not uncommon in the case of juvenile retinoschisis. And this hemorrhage has been there for some time already, so it is already yellowish. It doesn't have the red color. And the pre-op ultrasound was very chaotic. In fact, you really couldn't tell if the retina is detached. And the patient was turned down for surgery and was referred to our center for further management. So you can see that there's very thick organized vitreous hemorrhage, some of them old, some of them still red. But in addition, there's also very thick kind of schitic inner wall. And this is where it's just immediately behind the lens. And it suggested there was a very bolus retinoschisis with a very anterior displays that inner schitic wall. And so that was trimmed, and as you can see, once they were trimmed, that the retina doesn't look so bad. And you can see the optic disc there, there's a fold across with some of the kind of pigmented deposit or hemosiderin deposit over it. And then the peripheral vitreous was trimmed further to make sure that there's no tractions. So you can see that there is actually no peripheral breaks, and all of the situation that you see is just the inner retinoschisis with hemorrhages. And you can see the posterior edges of the schitic wall is elevated under tractions. As I mentioned earlier on, when you trim those areas, make sure you're not too aggressive, because if you trim to the bottom of those tractions, you actually create an entry to the retina, because the retina there is elevated. So it's actually better to lift the tractional band there. So I laser any of the suspicious area, just be sure that I didn't create any other problems. I also did an air fluid change at the end of the case. Sorry. Okay, so here is a nice publication from a group from India in 2018. It showed the surgical outcome of patients who undergo vitreoretinal surgery for rheumatogenic retinal detachment in X-linked juvenile retinoschisis. And you can see the overall anatomical success from the different publications back since 1993 to the most recent publication from this article were in the range about 80 to 90% success rate. So the surgical success for this group of patients actually is quite good. And it just needs to be managed in a timely fashion and timely managed appropriately. So that's the surgical approach. Here is one of the subtypes that we see in retinoschisis. It's called bolus retinoschisis. You can see when I first look at this case, and I thought I was looking at the optic disc and there's inferior retinal detachment. In fact, that's actually not the case. And you can see that on just through the ret reflex, you can see a very bolus anterior displays the retinal vessels. And in fact, what I was actually looking through is a very elevated bolus retinoschisis, because the schitic membrane was quite thin. I can see through underneath it, and you can see the disc and the retina elevations from it. And in fact, this was described by the group from I think from UK. They call this as a bolus X-linked retinoschisis, and they describe the clinical features associated with these appearances. And in this particular series, they reported 9 cases, and a patient can present with strabismus, and other features include vitreous hemorrhage, nystagma, tractional retinal detachment, or exudative rowdy, just like this one here, coat-like appearances. And what's interesting is that quite often the bolus schisis, just like the one that we saw earlier, can resolve spontaneously, and that can leave pigmented scar along the periods kind of border of the schitic changes. I saw in your poll question at the beginning of the meeting, people have mentioned about the use of carboxy anhydrase inhibitor. So there are quite a few articles published already of the effects of the carboxy carbonic anhydrase inhibitor, especially either the topical or the oral forms of the medications in treating either foveal schisis or peripheral retinoschisis. So here you can see one of the publications showing that the foveal schisis, and after treatment with the topical 2% dosolamide, the schisis goes away. So medical treatment using the carboxy anhydrase inhibitor has been helpful. And the exact mechanism is not fully known. It's thought that it will enhance the RP pump and allow that to settle down. And some of the cases with more bolus kind of retinoschisis, like this case here, using the topical dosolamide can have the kind of dramatic effects of resolving the schisis. Here's the OCT after the treatment. You can see the schitic separation that was seen earlier on has basically resolved. Although it is not perfectly normal, but still it is significantly improved. So here's another example of a case that Dr. Peter Curtis, which is one of my colleagues from SickKit, that we share on the management of this young 6.5-year-old boy, referred for management of bilateral retinoschisis, and there was nothing particular other than some late kind of developments of visual abnormality, mainly a bit of nystagmus and strabismus. And there's a positive family history. The cousin, who's 11 years old, has been diagnosed with retinoschisis, and the genetic testing confirmed the genetic defect in the RS1 locations. And there's also the positive family history of the maternal aunt and a female cousin with being a carrier of this gene. And here, it may not seen as well. You can see very bolus inner retinoschisis obscuring the macula and this in the right eye. And you can see the edges of the schisis extending nasal to the optic disc. And here, more of the picture of this same. And here's the left eye. You can see very bolus schisis. And so, as usual, decisions whether this should be managed surgically or observations. And having the knowledge of the dosolamide and the carbonic anhydrase inhibitor being effective, so we decided to go ahead with the treatment, dosolamide 2% 3 times a day to both eyes. And 3 months later, you can see the dramatic resolutions of the schisis. So I concur with the 44% of your respondent that even in such a dramatic cases of bolus retinoschisis, they do well with just the topical treatments. Here's the handheld OCT pictures scanning through it, showing that the schisis has mostly resolved with near kind of normal anatomy of the fovea. And here's the left eye with also resolutions of the schisis, leaving a retinal fold. So in the past, people might have gone in to try to do a inner wall retinectomy to fix that. I think that having the experiences from the others and looking at this case, this is a very dramatic result with just topical dorzolamide after 3 months. So to summarize that today, the spectral domain OCT has now made the treatment and the diagnosis of management of the extinct retinal schisis much more easier, and you don't need to do the complicated. Sorry, you don't need to do the complicated ERG, as most of us don't easily get access for their confirmations. The medical treatment of dorzolamide drops or using the Diamox will be an option to use. And surgical management with either scleral retractome without the inner wall retinectomy, the management of the choice for the more complicated cases, especially when there's vitreous hemorrhage. The use of plasmin to facilitate posterior vitreous detachment is still a controversial topic because it's not effective every time, and the preparation of the plasmin is sometimes complicated. As far as future therapy is concerned, as we coming to the era where gene therapy stem cell has become the newspaper headlines, gene therapy has been explored in the case of retinoschisis. This is a picture showing the gene therapy using the adenovirus vector loaded with human RS1 DNA and injected into mouse model. It's a knockout mouse model of retinoschisis model. The picture here on your left is the untreated one. You can see the disorganization and the separations of the retinal layers. And this one is a treated pictures of a mouse that was given the injections of this vector and this adenovirus vector with the gene replacement. And this is 1 year after the treatment. You can see the near normal anatomy of the retina and also the expressions of the retinoschisis seen throughout the retinal layers. So this could be the future for the management of juvenile retinoschisis instead of those kind of vitrectomy that we've seen that I showed you earlier. And I think at the moment there's still a lot of obstacle to overcome before the gene therapy is applicable for this particular disease. But the outlook is certainly good at this time. So I think that's the end of my presentations. I'm going to stop sharing, and I think I'm open up for questions. I used up my 20 minutes already.
Thank you, Professor Lam. We now open the floor to questions. You may post your questions either in the chat box in Zoom or on YouTube, or alternatively in Slido. Okay, so we have one question, Dr. Lam.
Yes.
Do you routinely perform genetic testing on patients with juvenile X-linked retinoschisis? And is this readily available in Hong Kong or in Toronto?
So to answer the first questions, so I don't routinely do the genetic testing. I will do them if I'm in doubt and if the family is interested to know if other members are at risk. So that's usually the basis when we do the genetic testing. Yes, the testing is available both in Hong Kong and also in Toronto. At the moment, I think the clinical diagnosis often are quite sufficient to confirm the diagnosis. Since we don't have any opportunity to do gene therapy, the information is useful but not very practical. So I don't think it's necessary to do the genetic testing for every patient with the juvenile retinoschisis at this time. I think this will be different if somebody presents with retinitis pigmentosum, because we now have a gene therapy for the Leber's amaurosis. So in the case of RPE65 mutations, we do have third. So for group the patient with retinal degenerations in the category of retinitis pigmentosum, I start doing the genetic testing so that that might offer an option to consider. Although the treatment at this time is very expensive, but it's something that at least that they can look into. So I don't usually do a test when it's not going to help my management.
Thank you, Dr. Lam.
Yes.
So there's a question. Vitreous hemorrhage is a common initial presentation of retinoschisis. So when do you decide to do surgery if a child presents with vitreous hemorrhage?
I think like any vitreous hemorrhage in a child, there is the risks of amblyopia. And so it all depends on the extent of the vitreous hemorrhage and how dense it is and how significantly affect the visions. And in the children's population, we tend to do surgery earlier if it poses a risk for the development of amblyopia. And we usually wait no more than a month to proceed the surgery. But as always, some of the hemorrhage can resolve on its own. So I think it's reasonable to wait at least a month to give the opportunity to occur. Yes.
Okay. There's another question.
Thanks.
In terms of medical management for carbonic anhydrase inhibitors, would an oral carbonic anhydrase inhibitor offer advantages or disadvantages compared to topical dorzolamide?
Yes, very good questions. And the literature actually shown use of both the oral forms as well as the topical forms. So I think, as we are aware, the systemic, like oral medication do have systemic side effects, and the topical has lesser systemic side effects. So I think that in most people, it will make sense to start off with topical the carbonic anhydrase inhibitor, such as dorzolamide, and then see if you are not getting a satisfactory response and you really want to give them a significant try, then oral medication may be worthwhile. The reason I say that is when you apply drops, the absorption may be limited, especially if the child cries and like all kind of things that can happen that may limit the amount of intakes of the medication. And that may be less of a concern if you use the oral medications. But bear in mind that you will have more systemic side effect with the oral medications. So I think you have to make that balance. But I think it will make sense to start off with topical, and if you still not getting your expected response and you want to try further, then the systemic option should be considered before you go to surgery.
Thank you. As a follow-up question, do you see recurrence after discontinuation of medical therapy?
Another very good questions. And I think you see different things. You see how you're treating, you get initial response, and then suddenly the patients have recurrent problems. These diseases either in the fovea or the periphery return despite the fact that the patient's still on medications. And that's probably sometimes you check with the compliances, and sometimes you increase the frequency of the drops or increase switching from a topical to a systemic medications. And another question from the same kind of perspective is, when do you stop, or do you stop at all? And I don't think there's a perfect answer there, because I think nobody done a long-term study and nobody done a prospective study to actually answer that questions. in most of the instances, people would probably keep the medication on, especially if it is just the topical form, because considering the systemic side effect or complication with the treatment is not that high. On the other hand, if it is oral medication, then I think it will be reasonable to look at stopping it or reducing it. And I think you first reduce it to see if the patient tolerates and the symptom doesn't or the problem doesn't return. And then from tapering, you may want to give the child a drug holiday. But there's no right answer to this. I think your clinical judgment will be the best way to manage these kind of situations.
Thank you.
Okay. I think
there's another question.
There's one more. Okay.
Last two questions. Have you seen patients, ROP patients, who eventually develop peripheral retinoschisis, or maybe as a complication of laser indirect ophthalmoscopy?
So for ROP, so talk about retinopathy or prematurity, I haven't seen retinoschisis, peripheral retinoschisis as a complications to the laser treatment. What's interesting though is that you can develop the foveal macular edema, like schitic changes at the fovea as a complication of prematurity. And that has been well documented because now people are doing more and more OCT of this group of babies. And I think some of those may be schitic changes, but nothing to do with juvenile retinoschisis, but probably to do with their prematurity or some of the abnormality in their macular development. But in the periphery, I have not seen, I cannot think of the reason why they should develop peripheral retinoschisis. If you see one, you should suspect they are retinal detachment rather than schisis, because laser do increase risk of peripheral tear and peripheral detachment, especially if the laser are very intense, and that can cause retinal necrosis and cause retinal breaks.
Thank you.
Okay. There's another question. In retinoschisis, if a hole develops only in one layer, will this actually not progress to the other layer and cause a detachment? And if it does, do you observe this? And when do you decide to go in?
So now, just talking about juvenile retinoschisis, the thinning occurs in the inner nuclear layer. So very often you get very thin atrophic inner retinal layer. An inner retinal hole can develop quite easily. If only the inner retinal hole occur without any outer retinal hole develop at the same time, then it's unlikely that you will have any retinal detachment caused from this inner retinal schitic changes. So if you see those, you can monitor those children or those patients without having to do anything surgically to fix them, because they can be very stable. For the outer retinal hole to develop, I don't think people fully understand the mechanism or the etiology, whether there is some progressive retinal degenerations that allow those to happen. For instance, you see that large outer retinal hole that I show you on the on one of the slides. That doesn't happen that often, but if it happens, and that will be the opportunity for the retinal detachment to occur, because that now you have communications from the outside, meaning the vitreous cavity, to the potential space of the separation between the neurosensory retina and the RPE. So if you have an inner retinal hole, in the case of juvenile retinoschisis, you can monitor. If you have an outer retinal hole, in the case of juvenile retinoschisis, it may not be a bad idea to treat that, because chances are you're going to get an inner retinal hole eventually because of progressive atrophy. So I think in that setting, there may be some justification to do something.
I think we have one last question, John.
Okay. Does observation have a role in cases with peripheral schisis sparing the macula and no hemorrhage?
Absolutely. I think that if you can observe, it's always better to observe because time is the best healing or healer of all treatment. And in the case you describe, where there's peripheral schisis with no macular involvement and you have no mentions of inner or retinal or outer retinal hole, I think the risk for progressions are very low. And although sometimes you do see progression of the schisis, that's true. But then schisis progression are not as a problematic as the rheumatologist retinal detachment. Number one is that the effect to the visual acuity is not as severe, and the rate of the progression is very slow. So I totally agree. Observation will be the best options.
Okay. Unfortunately, that's all the time we have for questions. Thank you for sending in your questions. We will try to address all the other questions and send you the replies via email. John?
Okay, so before we go to the second lecture, Dr. Jeff, if I may ask, during your fellowship, what was the highest cut rate of your vitrectomy machine?
I think in Toronto Western, Dr. Lang, we had the Accurus. It was 800 cuts, was it?
Yeah, somewhere around there,
Yeah. And I think in Sunnybrook, we had the Millennium, which with the extra module, we could do 1,500 cuts. And yeah, that was state of the art back then.
Yes.
Okay. So during my fellowship, I think our machine had 1,800 cuts. So I think with a number of cuts, you can tell the age of a person. So the age gap between Dr. Jeff and me. So we'd now like to give the floor to Professor Lam again as he talks about advanced high-speed vitrectomy. Thank you again, Alcon, for making all of this possible.
Right. Thank you. When I first moved to Toronto, I think they were cutting rate about 500. And in fact, they were quite proud that they were cutting at the 500 rate. So you can tell my age also.
Please.
let me share the screen. So let me just skip this one. Oops. So just give me a second. I think I need to.
Yeah, you need to open the.
Yeah, I need to close the last presentation first, and then open the next one. So it takes a bit. Give me a minute. All right, and so now I'll share again. Oops. Okay, and so you see the new PowerPoint?
Yes.
Okay,
Thank
so as we already said, this is my disclosure, and so this is how we start vitrectomy. So fortunately, I'm not that old, so but this is how it was first done, and unfortunately, it's still done by some of the anterior segment surgeons by using the wig vitrectomy. And then it was afterwards that Makuma start using the guillotine cutter, and the first cutter was actually 17 gauge, and I was told that it was actually the dental drill that was modified for that purpose. But that was the beginning of closed eye vitrectomy with the past cranial approach. The principle is using the guillotine cutter to chop the vitreous and to reduce any tractions. So over the years, you can see that a lot of improvement has made into the vitrectomy. Both the size of the vitreous cutter has getting smaller to the point that we no longer need to do suturing from the 17 to 20 to 23 to 25 to 27 gauges. And the cut rate from 200, 500 5,000, 7.5, and to a 10,000 cut rate. So the key to the reason why for the modifications or the improvement is that we want to be successful in retinal surgery. In order to do that, we have to be able to effectively remove the tissues that we want to remove, which is the vitreous and the scar tissues in the on the surface of the retina, and without causing damage to the adjacent tissue and damage to the retina itself, and that's the safety. So we have to be able to manage both the efficiency and the safety. And there are many reasons or factors that influences the safety and the efficiency, and such as the cutting rate and the instrument, how far is from the retina, and the amount of aspiration you create, and the duty cycle, which means when the period of the opening of the port of the instrument. Tonight, I'm going to spend most of the time talking about the cutting rate, and a little bit on the instrument itself, the design of the instruments. And it is quite intuitive to think that by increasing the cut rate, you will reduce the tractional forces by limiting the amount of traction that's created. So if you cut it very fast, then only small amount of the forces are being transmitted to the retina as you aspirate the vitreous into the cutting port. So that will reduce also any iatrogenic tear of the retina, especially in a situation when you have a detached retina. So are there evidence to suggest that cutting faster is better? Well, looking back in the couple of publications, you can see there are two publications look at comparing 5,000 cut rate to 1,500 cut rate on the 25 gauge system, and another study looking at 7.5, so 7,500 cut rate compared to the 5,000 cut rate. And they were looking at efficiency in terms of the vitrectomy time and the complication rate or the safety in terms of the incidence of the retinal breaks. And to no surprises, the cut rate, the vitrectomy time in the faster, the ultra high speed, which is in this case is the go back here, the 5,000 cut rate in the RESO study compared to the 1,500 cut rate. The time is significantly shorter in the faster cutting speed. So as the 5,000 compared to 7,500 cut rate is again shorter in the faster cut rate. So it is definitely more efficient in the higher speed cutter. And in terms of the safety, if you look at the incidence of the retinal breaks, there's a lower incidence of retinal break, only 1 compared to 13 incidence of retinal breaks in terms of the case comparing between the faster cut rate of 5,000 to 1,500 cut rate. And so it is similarly in the Mariotti study. It also showed that it is, well, sorry, in that they didn't find any significance in terms of the posterior detachment rate, but the incidence of the retinal breaks were higher in the lower cut rate. So the higher cut speed have shown to be safer in terms of reducing the incidence of retinal complications. We were interested to also look at what are the, because we're now moving to the 10,000 cut rate. So what are the evidence for the 7,500 cut rate compared to the 10,000 cut rate? So here is a pig eye model that they did using the 27-gauge high-speed cutter. And they were using the 2 different cut rates, and they were able to show that when you compare the 10,000 to the 7.5K cut rate, that doesn't matter which setting you use, whether it's the core vitrectomy cutting or the 50-50 of the shave mode, there is less traction generated with the faster cut rate, where it is about 30% reduction to about 20% reductions. So with the higher cut speed of 10K or 10,000 cut per minute, there is significant less vicious tractions that were seen. So that is a pig's eye model. So in Hong Kong, we were interested to see what happened if we do it in a human case when we actually use that for the surgery. So we did a study comparing the using a 25 gauge vitrectomy system, comparing 10K versus the 5K vitrectomy system. And so we were looking at the similar parameters such as the core vitrectomy time and the incidence of retinal breaks. And you can see there is a longer vitrectomy time for the 5K compared to the 10K cut vitrectomy system. And when you look at the incidence of retinal breaks, there are 4 cases of retinal tear. There are 4 retinal tears formed in 3 cases compared to 1 retinal breaks in the 10K system. So although the number is small, so there is no statistical significance in terms of comparison, but you can see clearly that the faster cut rate has lesser incidence of complications. We are also interested in terms of the flow rate, because one of the things that people will consider as you move to the different gauges of the instrument, and with the different cut rate, because you're cutting so fast, are you maintaining the same flow as you will be for the different cut rates? So you can see, first of all, the purple lines represent the 10K, and the blue represent the 7.5K, and the red being the 5K. You can see that the flow rate is consistently better in the case of the 10K, whether it was at a different cut rate. And that was the 23 gauged. And in the case of 25 gauged, similar patterns seen that the flow rate is also consistently better between the different cut speed and of the different sizes. And so you can see that for instance, if you look at the 7.5 compared to the 10K here, the 10K are more efficient in terms of the increase of flow rate at this cutting level. And for the smaller size, like the 27 gauge cutter, it is still performing better at the different cut rate. At the higher the cut rate it does, is still doing a very effective, making a very effective flow rate. So that was the in terms of effectiveness of the flow rate. But then the question asks about the tractions, and that the different cutter have the different generation, different tractions. And this one looking at the peak traction between the different gauges, 23, 25, 27. And this is very interesting here, that in the case of the 23 gauge, when they are cutting in a high rate, it actually has a higher tractions at if you use a 23 gauge cutting compared to the cutting at the 10,000 cut compared to the 7.5K cut. So that means in the 23 gauges, using a high cut rate, you actually need to reduce your aspirations or the vacuum, so to not create so much tractions or that can induce the risk of retinal break. On the other hand, if you look at the 25 and 27 gauges, the higher cut rate will actually keep the traction rate being low between 18 to 38% low. So they are safer without generating that kind of tractions that may increase the risk of retinal breaks. During the ASRS survey back in 2014, people asked the different surgeons of what is most important to the Richards cutter. Most of the people responded ranked the cutter performance as one of the kind of major interest that people have. And the changes in terms of the cutter design has been evolving from the driving technology as the Alcon has developed this dual pneumatic driver would allow a more effective or more efficient increases, having the port opening more than almost doubling the previous design. And since we already talked about the cut speed, having the better efficiency and reduce retinal breaks, the next thing that comes into the equations of improving the cutter performance will be the design of the cutter. And the newer design for the Richards cutter or the high-speed cutter is bringing the cutting port closer to the tip of the cutter, which allow more effective or more efficient cutting. And so here's the comparisons of the 25 plus cutter that you can bring the cutting opening closer to the surface almost by twice the or half the distance that's needed, so that you can work very close to the retinal surface without having to worry about contacting the retina itself. Here's example one of the surgery we did in the case of retinal detachment where there's a retinal brick. You can see this case of a 10K, I was able to bring the cutter very close to the retinal surface without generating a lot of detraction. So you can see, go back to the film, that during the removing of detraction near the port, you can see even the band or the ridges over the retinal bricks are being trimmed. The retinal fluctuations are very minimal or relatively controlled. And the close proximity of the cutter to the tip allow you to use the Richards cutter like the scissors to do delamination and segmentation. So in the case of diabetic tractional detachment, you can use that to cut membrane and trim off the membrane effectively without the need to switch to a scissors or forceps to do this. And so the newer cutting design, the cutter design allowed this maneuver much easier to achieve. So to summarize, the high-speed cutter with the higher cut rate reduce tractional forces, and that will reduce the fluctuations in the pressure during the procedure, and having more stable fluidity during the vitrectomy, both in the core as well as in the periphery. And the increasing efficiency by shortening the vitrectomy time, although it's not the critical issues, but it will help to allow a quicker turnover of the cases. But more importantly is the increased safety by reducing the tractional force that can cause retinal detachment. So, so with the increasing speed, I think, especially with the coming of the switching from the 5K to 10K, I think Alcon eventually going to phase out for the 5K cutter. I think we're going to have the opportunity to do our love the surgery in a more safe and an effective manner. I think I will finish my presentation here.
Thank you, Dr. Lam. Are there any questions, Joanne?
Okay. Maybe we can ask Dr. Lam to comment about pneumatic cutters versus electric cutters.
Now, I haven't had time to think of the cases of electrical cutter. I haven't had the chance of using electrical cutter. So all this kind of time that I have the opportunity to practice is always the pneumatic cutter. So I'm not the expert to able to explain to you the difference between the two modes of cutting. But what's interesting though is that the newer retractomy from the VRchannel is the hypersonic cutter. They are very effective using the hypersonic mechanisms to break down the tissues compared to a pneumatic cutter using a guillotine cutter. I think there's advantage of using that kind of hypersonic cutter to remove the jelly, but you can see in the last set of surgical slide that the pneumatic cutter work like scissors and a cutting instrument. So I think I'm not sure the hypersonic vitreous cutter will be effectively replace the vitreous cutter that we're using. Although it may allow the retractomy part of the surgery easier to accomplish and safer to accomplish because it doesn't create as much tractions. But I think you will end up needing other instruments to accomplish other part of the retinal surgery. I welcome comment from other people about the electrical cutters. I just don't have that experience.
Thank you. Dr. Jeff?
I also have no experience with electrical cutters. I remember the millennium before, with the additional module, it was electric, right? But the 1,500 cuts.
Yeah, I don't know.
But it was a long time ago. It's old
I don't
technology,
know.
so I don't know.
Yeah, I don't want to say.
Yeah, but I remember the millennium before, if you had that extra module to convert it from 750 to 1,500, I remember it was electric. But
I think that's probably some limitations on the mechanisms, because if it is a very good system, you should see more of them being used. So, but I think you're right. I think the millennium were using the electrical cutter, but then the millennium get kind of displaced in the market for quite some time already.
There's a question here. When using smaller gauge and faster cutters in cases of dense vitreous hemorrhage, do you change your parameters or settings?
In truth, I don't. I think I do the surgery the same way. The setting I use is a proportional retractomy. So depending on your foot positions, whether you can do doing a lot of aspirations with this fixed cut rate, or lowering your aspirations when you're cutting on a area where there's, let's say, retinal detachment, or area that you want to reduce your aspiration to avoid drawing too much stuff towards your cutter. I usually kind of managed the cutting or the retractomy by using that kind of approach. So in the case of vitreous hemorrhage, it's probably very straightforward. You use a maximum cut rate and maximum aspirations to complete your job until you get close to the retinal surface, where you either have some location of tractions, or there are areas that you worry about getting too close to the retina, where you then regulate your aspiration by reducing your foot pedal pressure. So I don't adjust. I think you can see from the previous slide the flow rate of of the different size of the cutter, even within a very fast cut rate, the flow efficiency is actually there. In fact, it's the high the cut rate with the newer design, they are actually more efficient. So I don't think you need to reduce your cut rate to do a good retraction these days. That's different than the old days.
Okay. So I don't think
There's a question.
there's another question. Do you prefer proportional vacuum, 3D vitrectomy, or momentary especially for membranes?
Yeah. So I already said my default setting is proportional, and I don't use the 3D. I think the 3D was designed to help people to kind of because the first part of the foot pedal cutting in a fast rate but lower aspiration, and as you increase your foot pedal, it becomes faster and more vacuum. I sometimes get confused with that design of the 3D, so I just go to the proportional for most of my procedure. The momentary are useful for the cases like creating an iridotomy, and because you have a single cut or a few kind of bursts of cut to create a retinotomy without making it too big. And other uses for the momentary setting is for taking out the dislocated lens material, so that when you engage that chunks of lens, either cortex or some slightly hardened nucleus, you can use that, set the cut rate at, let's say, much lower, like 250 or 300, and then do that for those specific occasions. So that's, for the momentary, that's what I use only for either doing iridotomy or doing a lensectomy. Otherwise, my default mode is proportional. Yeah. What about yourself? What do you do?
John, do you use? I don't use the constellation.
Right.
John does. So,
Okay.
John, do you have any comments?
So we use a constellation machine at St. Luke's as well. I think majority use proportional also. Yeah. I
So
think
there's one last question from Nats. What is your comment on the EVRS retinal detachment study that Venturi-based machines have a higher complication rate compared to peristaltic machines during vitrectomy?
Oh, I I think you have more to do with the surgeon than the machines, I think. So I think two things I have to say. It's like the car, right? You driving the car, is the driver is going to get into the accident. The car never get you to in an accident. So you should be able to adapt whatever machine it is, whether Venturi and peristaltic. Is once you know your machine, then you should be able to use it effectively for whatever you're doing. And because I do not have a bias to either peristaltic or a Venturi system, I think the surgeon will be the best person to judge what suit his style of surgery best for the type of machine that they use.
Yes. So I guess that's all the questions for today. Thank you, everyone, for attending, and thank you very much, Dr. Lam, for your wonderful talk, and thank you, Alcon, also for your continued support. Everyone, please scan the QR code to sign the attendance, and then answer the survey and download your certificate of attendance. You can also click the link posted in Zoom and YouTube chat box. The form will be accepting responses for the next hour. Thank you again.
Yes, thank you everyone for participating. I'd like to thank Ryan, Camille, Paul, and of course Jubes for making all of this possible. Hope to see you at the next VRchannel, which will be on August 8th with Dr. David Wong. of Toronto. So same time, same channel. See you next month. Good
See you
night.
all. Bye bye.